Hello, hello. Hi, welcome everyone. Today is Wednesday, May 1st. It's the first day of May. For us millennials, it's gonna be May, according to Justin Timberlake. So that's always today's the day that you can play that obnoxious meme to death. So I kind of hide from the internet until tomorrow because I'm like, I really just don't want to see that meme over and over. That's back when he had his ramen noodle hair, which kind of freaks me out a little bit. So we're definitely gonna skip on that. But it's May. It's Taurus season. I'm May 26th birthday, so that's Gemini season. So May's a good month. It's also maternal mental health. So that's super important in the OCD space. We know that perinatal OCD is a time that really impacts women with OCD. So happy Maternal Mental Health Day. And I'm excited to be here. So we're going to kind of do a little bit of housekeeping stuff, and then I'm going to introduce my guest. Liz McIngvale, my co-host, will definitely be here. She runs one of the busiest OCD residential, so sometimes she gets called to emergencies, the OCDI in Houston, Texas, but she'll be on in a second. But just to get some housekeeping out of the way, so this is one of the live streams. We have live streams twice a week. Consistently. So Tuesday evenings at 4 p.m. my time, 7 p.m. on the East Coast, where Mona and Kat are. And then on Wednesdays at 9 a.m. on the West Coast, and then 12 noon on the East Coast, where Mona and Kat are. So this one is, we have Lunch and Learns. Today is an Ask the Expert. So we're really bringing on people that can sort of give you information, whether you're a new clinician or a seasoned clinician, you're a parent or loved one of somebody with OCD, or you have OCD and anxiety yourself. We always try to bring you different experts to talk about different aspects of the disorder and the treatment. And today's no different. So we're excited to jump in. Before we jump in, we always have to talk a little bit about housekeeping. So this live stream is really intended to be educational. We want to give you resources, community, education, and hope. What we can't do in this capacity is be a crisis center. So if you are in crisis, please make sure to dial 911, go to the nearest emergency room, or you can dial 988 or go to 988lifeline.org. So those are ways that you can get safe, and make sure that you connect with your clinician as well. And then lastly, this is being live streamed and recorded on multiple platforms. If you come in late or you want to share this with someone, you can go to youtube.com/IOCDF, where all of these are uploaded along on the IOCDF's Facebook. So we're going to jump in. So I'm going to introduce my guests. So first, do you like Kathryn or Kat better?
Let's go with Kat.
Okay, sounds good. That's my initials, by the way. Just not a very exciting little fun fact, but
that's why I chose Kat.
For sure. All right, so Kathryn, aka Kat Boger, PhD, ABPP, is a board-certified child and adolescent clinical psychologist who has devoted her career to helping children and teens with anxiety and obsessive compulsive disorder. She is passionate about improving care for youth with these disorders and decreasing their suffering through innovative research-based treatment approaches. In 2013, she co-developed the McLean Anxiety Mastery Program, MAMP, at McLean Hospital, nationally recognized for providing empirically supported intensive anxiety and OCD treatment. She also served as an assistant professor in psychology at Harvard Medical School and has published peer-reviewed journal articles, delivered regional and national talks, including a TEDx talk, and provided training to hospitals, schools, and the community. She is the author of a children's book, Step by Step, about facing fears and being brave. In 2021, Dr. Boger, am I butchering your last name?
No, you're doing great. A lot of people try to say Boger,
well, that's where I shop at Target, so I was almost going to say Boger, but I wasn't feeling too bougie. Co-founded InStride Health with the mission of increasing access to insurance-backed research-based care for children, adolescents, and young adults with anxiety and OCD. So welcome to the stream, Kat.
Thank you. So pleased to be here.
I am happy to have you as well. And then Dr. Mona Potter is the co-founder and chief medical officer of InStride Health. She is board-certified child and adolescent psychiatrist with 2 decades of clinical and training experience in the Mass General McLean Hospital system. She has worked across all levels of care and with the range of diagnostic presentations, and has developed a strong appreciation for the incredible impact the right treatment and support can have on pediatric anxiety and OCD. Immediately preceding InStride, she served as an assistant professor of psychiatry at Harvard Medical School, Medical Director of McLean Hospital's Child and Adolescent Psychiatry Outpatient Services, including the McLean Anxiety Mastery Program, Associate Training Director for the MGH McLean Child and Adolescent Psychiatry Fellowship, and is on the leadership team for the McLean Institute for Technology and Psychiatry. Building on her experience and expertise, not only as a child and adolescent psychiatrist, but also as a parent, Dr. Potter was motivated to co-found InStride to improve access to insurance-based care that works for pediatric anxiety and OCD. Welcome, welcome.
Thank you.
Oh, my vocal cords got to work out there. Y'all doing so much, making me look like I have nothing going on in my life. Thanks a lot.
No, as I was listening to you, I was thinking we gotta shorten our bios a little bit. Yeah, let's do some cutting.
Well,
we have some talents. Being concise might not be one of those cats.
It's all good. Well, we're super excited to have you. Like I said, it's always good having different experts on to kind of share with us, just what options are out there. I mean, I think first and foremost, so many people are in areas struggling to find care, struggling to find higher levels of care. So that's super important. So one of the things I want to start at is you did talk about InStride having an intensive program. Can you tell people watching a little bit, what is an intensive program and when does somebody need a higher level of care? What are some of those signs, whether it's a clinician that should refer out to a higher level of care or a parent or a person with OCD that might benefit more from a higher level of care?
Yeah, if you want to go for it.
Sure, I'll jump in there. I think that the traditional once a week, 50-minute model, it works for many people and it can move the needle. I think that when OCD reaches a certain level of severity, so the level of impairment in somebody's functioning has gotten to a certain point, it can be hard to get traction in that once a week model. And so if you think about the care we provide is CBT with a big B, meaning the behavioral piece is really what is driving the outcomes. And there's so much of an emphasis on exposure work. And when a kid, for example, is not attending school, when they're not interacting with their family, when they're not engaging with peers, doing their extracurriculars because of the severity of their symptoms, coming into session, talking about the week, planning for the exposure, doing the exposure, somehow magically getting out in the world and having that exposure, then generalized by being in a store, being in a school, et cetera, and then processing is incredibly hard to do in that once a week model. And so with intensive treatment, what we're doing is providing multiple touch points a week of therapy. And so this is a lot of exposure work, the cognitive work, the emotion piece, doing that out in the world. We provide exposure coaching to help generalize the learning and help engage kids in the care, help them practice their exposures in multiple settings, groups, and then so that kids feel less alone and they have other kids who can kind of cheer them on, talk about their experience, normalize, and then med management. So the idea being that you're really getting wraparound care, your providers can work together to help you get back on track more quickly and really build that momentum. Because for a kid or a teen who is struggling at that level, they've really fallen off the developmental curve, the losses start building up quickly. So the sooner you can get them back on track, the more you can build that momentum, the more you're staving off other issues down the road.
Well said. And Mona, can you tell us a little bit about InStride, where you located, what are some of the services you provide, and what is the treatment approach that you all take there?
Yeah, so InStride, Kat and I were just talking this morning. We worked together at McLean for, what was it, Kat, 12, 15 years before co-founding InStride. And when we first started at McLean in our anxiety program there, we had this vision for saying, we just want to be able to just make sure that anybody and everybody who has anxiety, who has an anxiety or OCD diagnosis gets kind of access to treatment that they need. And what we found was that that in an academic center, you're able to provide really great treatment. But what we were finding, people were having to relocate in order to get that treatment, or people were having to pay out of pocket because what we were doing was a little bit different from kind of the traditional fee-for-service model. And so we built InStride directly from kind of what we were seeing on the ground and where we felt there was a gap, knowing that there's incredibly effective treatment that, again, as Kat was saying, that exposure-based treatment really makes a difference. Not getting the right treatment also, like it can be devastating. And so for us, this is absolutely something where we want to make sure we're doing right by every child and family. We're pediatric clinicians, and so again, we think about the child, teen, young adult who comes to us, but also the system in which they work, or in the system in which they live. So we've built in Stride as really what we call a systems-based care. Kat kind of described it. It's we work with kids, teens, young adults, age 7 to 22, who are diagnosed with anxiety and/or OCD. Oftentimes, they go hand in hand, and we use evidence-based treatment, CBT, at our core, with again a big emphasis on that behavioral aspect, making treatment very active. Oftentimes, what we see is that it's very easy to talk about what we're going to do differently and talk about the pain that it causes, the losses that happen, and there is a supportive aspect to that. But the change really comes with showing showing your brain that engaging in those things that are uncomfortable, or engaging in things that OCD tells you cannot do, actually helps create that dissonance between what is true and what OCD is telling you, and actually helps shift the behaviors, helps you move towards the life that you want to live rather than the life that OCD is kind of needing you to live. And that's just easier said than done. So it really is about that intensive phase being, we are in this with you. We are all together. We know how hard it is. You are highly motivated for a different life. And actually following through on the things you need to do it is really hard. And so that's where having not only that therapist support teaching you and working with you hand in hand, but also that coach saying, I'm holding you accountable. Like, I'm going to cheerlead. I'm going to make sure that you don't feel alone through this. And I would say that the psychiatry piece is like, I'm a psychiatrist. It's like oftentimes like we're all just busy and it's really hard to coordinate. And so I would have somebody come to me and say, it's just getting worse. I don't know. And my tool is a medicine. And so it's like, well, here, let me give you medicine. So oftentimes we see kids coming in on lots of medication with, and it's hard to know what's been helpful and so for us, it's a really talking about the medication as helping you access the therapy. So we're trying to dial down that intensity of the emotions, intensity of the OCD, so that you can engage in those approach behaviors. You can engage in that exposure work, and taking the feedback from the therapist. And Chris, you should interrupt me, because once I get going, I just go. So,
well, I have a couple. No. Thank you so much for the information. I was going to say, one of the things that you spoke to, as somebody with OCD, I always think the way that I think of the C and the B in CBT is, I've always felt like, looking and reflecting back on my treatment, I always felt like there needed to be more of a cognitive piece. I think my OCD was so intense to the point where logic was out the window. I mean, one of my fears was getting drunk and I might lose control and harm someone. And I remember one time just driving by a billboard for Coors Light and thinking, could I get drunk from that? And actually pulling over and sleeping in my car to sleep off the alcohol, right? So I think cognitive is so important. But I like what you said about the emphasis on B, because to me, what B stands for is like, you're backing it up, like you're putting your mouth, your money where your mouth is.
Exactly.
So I agree with that.
And when I first started treating OCD, I would get in all kinds of back and forths with the irrational, like let's catch that thought, let's check it, let's change it. And I'd realize, kind of similar to substance abuse, like motivational. It's like the more struggle you get into, the more that person is feeling tied to those thoughts. And it's like, oh my goodness, I got to stop doing this struggle here. And like, let's absolutely identify when OCD is showing up, when OCD is telling you, is interpreting the world for you. And simultaneously, it's not my job to convince you it's wrong. And there are ways in which it is trying to protect you. And so it's messy. It's messier than sometimes we think it is. And that's why I think that behavioral piece, the action-oriented part, is an important part to go along with that cognitive part.
Well, the prettier half of the hosts of this show just arrived. Hi, Liz.
Hi, y'all. So sorry I'm late. So happy Chris could get started today. I'm so excited for this live stream. So I'm sorry that I'm hopping in a fourth of the way, but really excited to be here.
Yeah, one thing I wanted to ask you, Kat, we got a question early on, and I think this is good for a lot of people because they hear us talk about like a lot of our centers treat both OCD and anxiety. And so we got a question, Amanda, at 12:02 from Dr. Hassan, who said, is it common to have OCD and general anxiety disorder together? What is a prognosis in such case? So do you see both of those arrive at in Stride and other treatment centers? And what is the prognosis and how is it different?
Yeah, no, it's a great question. And so the short answer is yes, we see a fair amount of comorbidity, OCD with a variety of anxiety disorders and or depression. And I think the good news is that we take a trans-diagnostic approach. And so instead of saying we're going to have one protocol for OCD and one for GAD and one for specific phobia and one for separation, et cetera, and it could just go on and on and on, we have a trans-diagnostic curriculum where we're hitting on core mechanisms. So we're hitting on cognitive inflexibility, emotional avoidance, behavioral avoidance with all of our interventions. And because we work with kids and really specialize in moderate to severe, we also have complicating factors guides. So we recognize when anxiety, when OCD gets more severe, that there are going to be other complexities, for example, school avoidance. And we want our therapists to be equipped to both use a trans-diagnostic curriculum, but also have the understanding of how would you navigate this case in light of the fact that this kid has been out of school, let's say, for 6 months.
Totally. And I would love for some of our viewers, if y'all can just explain what trans-diagnostic means, just because some of our viewers are not clinicians, and it would be so useful for them to understand. Because the reality is not just most of our viewers, but most of the patients any of us treat, especially when we're treating, above moderate levels of severity, they carry multiple diagnoses.
Yeah. No, it's a great question. So essentially, it's crossing different diagnostic presentations, and our trans-diagnostic curriculum crosses the anxiety disorders and OCD, if that makes sense. And we do a comprehensive clinical evaluation up front. And really what we're understanding there is like, what are our primary targets specifically when it comes to exposure? So when we're building that fear and avoidance hierarchy, what are going to be the target on that hierarchy or hierarchies? Because often we know that kids can have multiple hierarchies. But at the end of the day, we have this sort of the same core components. So we're doing, for example, the cognitive work, and we give options of, are we going to go for this kid in a more diffusion route, or are we going to go more in reappraisal route? And for some people, there's actually, for example, with various anxiety disorders, it's helpful to have both approaches and they can kind of choose in the moment. But everybody gets mindfulness. Everybody learns how to just sit with and be with their emotions, for example, and exposure is a given.
Yeah.
I wanted to ask, go on.
No, I was just going to say, I think 2 things I wanted to mention based on kind of discussion so far. And the first is that, every diagnosis has an evidence-based intervention. And it's really important for our listeners that, we've talked a lot about this. We've talked about how do we differentiate? How do we know where to start? How do we know which intervention to use? But this is so important because actually, even if a patient is living with GAD and OCD, treatment looks similar, but it also has some very different components, right? And the way we approach it, the way we focus on response prevention for OCD, right? All of these different things play a big role. And so it's really important. I always tell everyone that you do want to really spend time in that assessment phase to understand, what is my full presentation, right? What does my disorder look like? And as somebody, we run obviously a residential level of care for adults. We sometimes learn more and more 2, 3, 4 weeks in, right? 2 weeks in, 3 weeks in, we're saying, hey, there's also this going on. And let us further assess for this and understand. And so I say that just because, I'm curious how often you guys bring on a kiddo, right? Or an adolescent, not kiddo necessarily always, but you bring on somebody that you're like, okay, this is what it looks like. But maybe 2, 3 weeks in, especially in intensive treatment, how often are you saying, hey, this is also coming up. This is treatment interfering, and we need to make sure you're getting treatment and focusing on this.
Mm-hmm.
It's such a great question too, because part of the treatment process is building awareness. And so I think we have kids who come in and they're actually not aware of the different ways in which their anxiety manifests or their OCD manifests. And so as treatment goes on, the awareness increases, the family's awareness increases. So absolutely, our conceptualization will shift. We do at the outset a really comprehensive conceptualization where we're identifying what are the contextual factors in the family, what are the diagnoses, what are the goals, and specifically, what are our targets for the patient and targets for the family. I think that oftentimes that family piece can be missed. And when you work with kids and teens, it's really important to get everyone aligned around where you're headed, why you're headed there, what matters to this specific family, and how are you trying to move the needle. And then you can keep reevaluating as you go.
I would love to hop into that because that is my next question is tell us about family involvement. What's it like in y'all's treatment model? And also just with your background and experience, talk a little bit about why it's so important and why families need to be actively involved in treatment. Because what we know is that, especially for the age group you're treating, right, you can't treat the individual and not treat the family system that they're a part of.
Yeah, I'll say a couple of things, and then Kat, this is your jam, so I'll let you take over. But the family piece is the part. So when we were first developing this program at McLean, that was the piece that we enhanced and added more than any other component of our treatment. And even when you look at the research, I mean that family involvement, again, that system, that environmental piece, and how that environmental piece interacts is so important. And as a parent, I'm sorry, I mean, it's like when your children are really struggling, your own mental health, like there's also that own kind of how am I doing and what am I modeling and piece of things. And when you have multiple children, what works well for one child might not work as well for another. And so again, there's so many different reasons that we highly value that parental piece in there.
Yeah, I would just add that the care we provide is purposely time limited. The idea being that we are not trying to create perpetual patients, kids who are like, I'm going to be in therapy for the next 10 years. Instead, our goal is to give the system surrounding the kids, give the families, give the schools a new way to respond to the anxiety and the OCD. So we're really activating that environment so that beyond InStride, they don't need InStride. They're their own care team, and they know when they have those bumps in the road, because the road to recovery, it's bumpy. So when they hit those bumps, both the child, but also the family knows how to respond in those moments, how to be effective. And they also know to just expect those bumps, that those are going to be a given in the process. So everybody is not up in arms when they encounter the bumps. So I can tell you how we work with families, if that's helpful.
That'd be great.
Yeah, we include families on multiple levels. So we have an initial parent and caregiver skills group. So it's an 8-week group, and we're teaching the fundamentals. So we're teaching about validation, or about removing accommodation, about labeled praise, etc. And then beyond that, we have an ongoing parent and caregiver practice group, because as a parent myself, I know it's one thing to talk about the skills and strategies. It's a whole other ballgame to try to implement. It is messy. It's really hard. Extinction bursts are brutal. And so the idea is that you can then, as a parent, come back to group and say, all right, I tried this thing, this part worked, this was really, really hard and messy. What feedback do you have? And both the group leader, but then also the other parents and caregivers can give support, because I think when you're a parent and your child is struggling, it's really isolating. You feel like you're the only one. And so having encouragement from other people is so, so powerful.
And just having those like reminder tips, like I always tell people, guys, like I'm a behavioral therapist for a living, right? This is what I do. It's what I live and breathe. And like, I need help with my kids. You guys, I just rehired a sleep consultant this week because my 3-year-old, we transitioned to a big kid bed and I thought I was going to die. And it's funny, like, granted, I don't need as much. Like, we had one meeting and like, we are good to go. Cause she's like, well, you're just following everything I said. I'm like, yeah, I can follow what you tell me. I'm a behavioral therapist, but sometimes like even those of us that know this, we're trained in it. It is so hard when we're talking about your own child crying and screaming and anxious and shaking in front of you for you to like know exactly what to do. So I love that they get those skills, but then they also have opportunities to re-engage as needed and to come back and say, okay, I'm stuck with this one, or here's a new one OCD threw at us. Can you help guide me?
Yeah.
There's nothing that brings up our own emotions like our kids, right? It's one thing to to think about applying skills when everything is like cool and calm. It's a whole nother thing when we're in emotion mind, and now we're trying to remember what was that skill or strategy because it's out the window. One of my kids had tonsil surgery in the last 2 weeks, and I teach validation every day. I was tired, overwhelmed, and this morning I skipped right over validation. I went right to you're okay, you're fine. I'm like, what do I do here? I teach the opposite. Again, I think that's where it's really helpful to have not only the reminders, the accountability, but just some peer support and recognizing this is hard and we're all doing the best we can.
100%.
And you talked a lot about family involvement. Can you talk about, we get a lot of newer clinicians. That's who I get a lot of messages from that watch the live streams. For newer clinicians, what are the differences? I mean, your program really focuses on child, teen, adolescent, OCD, and anxiety. For clinicians or for psychiatrists, what are some differences maybe than treating the adult population? What are some things that your program does different to cater to that age range?
Yeah, I mean, I think the family component is a big one, but I would say the school piece also. So these kids spend a lot of their day in school, and that's another place where it's great opportunity to practice the new skills. Because what we see oftentimes is school people wanting to be kind and supportive and build good relationships, and in that context, they help with the avoidance, which, as we know, really might make things feel better in the moment, but actually perpetuates and kind of strengthens the OCD in the long run. So it's kind of teaching and encouraging kind of something that doesn't quite feel right from a relational perspective. And so a lot of times we'll get kids coming into us who are having a harder time engaging in school, either because they'll either go and spend a lot of time in the nurse's clinic or in the guidance office or texting parents to say, bring me home, or ultimately having a hard time even getting to school. And so there's a lot of work we'll do with the teams at school to say, all right, here's what, your point, Liz, here's our assessment of what's happening. And here's what we all need to do, even though it doesn't feel kind in the moment. If we're all on the same page and doing this deliberately, this is in the long run much kinder. So that's, I would say, a huge piece that is central to what we do.
The other piece I would add is that when you're an adult going into treatment, you're making that decision because the struggle is big enough that it's worth it for you to take the time to meet with a stranger, to open up. For kids, they often feel like it's like parent mandated when they're going into treatment. This is not their first choice. There are a lot of other things they would rather be doing. And so similar to work with adults, we have to make it meaningful to them. And for kids, that can mean something different. So of course, we're connecting with kids around their values, around what matters to them. We also take a strengths-based approach. So we're identifying what is really cool about this kid? What makes them tick? What matters to them and what are they proud of? And we're really connecting around those things. And then I'd say we try to make it very active. So it's virtual, but it's not virtual like what we're all doing right now. This is I was going to say this is stagnant. This isn't stagnant because this is a fun conversation.
That's okay. Yeah.
Dang, we just got shaded on our own show. That hurts. Take them off the list of guests.
Yeah, no, you can take me right off right now. Just check me from
It's like, it's not as boring as this live stream. We do fun stuff.
This is a super engaging, fun conversation. And with these kids, we have them put their headphones or their earbuds in, and they're out in the world.
They're active.
They're active. Or maybe they're shooting baskets with their coach virtually, or they're going for a walk, or they're doing their interoceptives, or they're in school reaching out to their coach because they're having a panic attack in the bathroom. But it's really active. It's really engaging. And they're interfacing with their fears out in the world. They're not just in the office talking about it.
Yeah, which I love so much, and I think that this leads into a few questions I want to make sure we cover. And then we have a lot of live questions. So I'd love for us to hop to those so that we can make sure we get to those. But, I think that there is so much belief that, virtual is just like this boring computer, where it's actually no, virtual is when we can't be in person doing active exposures together, we can now do that virtually. And that's so incredible, right? A lot of clinicians don't have the flexibility to be able to go into the community with their patients and do those sort of things where you guys can. And that's awesome. So I want to talk for a second about y'all's program and then ask a couple questions because for all of our viewers, there's a couple reasons I wanted to make sure that both Mona and Kat were on today. Number one is they're incredible. They come from, you got everyone on our program that, you know, we all know about McLean. We know about McLean's background and history and their incredible programming. And, you know, obviously in the OCD world, right? First ever OCD Institute was developed by Michael Janicki and Diane and Denise over at McLean. And, you know, there's just so much that comes from there. So we know you guys, I told Kat this, I was like, I know you're a sound, incredible clinician, which is amazing, but this is one of the first programs I know of, if not the only program that I actually know of, that does evidence-based intensive virtual care for OCD that accepts insurance. That's really OCD and anxiety specific. And there's a couple things I always tell people. Number one, you have to be with a trained clinician who really has training and background, not somebody who went and did a 3-day training. Like, yes, that's great. That's better than nothing. But if you need more intensive treatment, I want you asking, where was someone trained? What was their background? What was their experience? Have they had experience with a more severe population, right? That's really important. And number two, right, are they doing evidence-based treatments, right? Those are some of the big things. And so I am just so excited to be able to talk to our community about not just your program, but also the fact that you guys are in network and that this is an intensive option available. So I would love for you to just tell us like who you serve, how people can find you guys, and of course, like what insurance and payments look like. Because one of the things we get is that many of us, myself included, have not had the luck, if that's what we want to call it, to be able to accept insurance. You know, unfortunately, insurance and payers can't agree to our rates. I try every day. I fight with them every day. It's not fun. Mike Janicki has a lot of his famous conversations of throwing phones against the room, you know, while talking to insurance because of the difficulties. But y'all have been able to figure it out for this population and group. And that is just so incredible and is such a resource everyone needs to hear about. So would love for y'all to tell us a little bit specifically about who you serve, how they can find you, and what payers you guys are in network with.
Go for it, Mona. I've been doing it.
Sure. Yeah. So we're pediatric specialty. So we work with kids, teens, young adults, 7 to 22. We will sometimes stretch up in age depending on kind of comfort level, kind of what's going on. Stretching down is a little harder because a lot of our work is also group work and individual work. And so, but with the younger kids, oftentimes the parents are even more involved in treatment. And you can find us just by going to instride.health. It's our website, and we're trying to make it. We've worked really hard on our inside work, and now we're starting to work better on kind of our external. So our website is, you're going to notice that it's going to get updated and improved, but I think it's a reasonably easy, user friendly. Just go and click start here. But I'll say that the insurance piece has been the biggest learning curve for me. It was one of the big reasons we spun it out of academic medicine of McLean, because we needed to be able to go straight to the insurance companies and negotiate directly with them for this very specific program. And I'll say it's been kind of, I've done a lot of that work with our team, and I find it really fun and challenging because it is, this is something we believe in and something that should be delivered. And also that we have to do it in a sustainable way for us, because if we don't, then we're going to have to compromise on the care we're delivering, which is not okay. It's just not okay. These are kids and families, and so we are slowly but surely making our way in network. So we are not in network with all commercial payers yet. Each conversation is a conversation that involves many different parts of the payer, and then operationally we have to integrate them into our system. We do a very unique collaboration or contract with each payer. So it's not a small deal, and it does take a team of amazing operational workers, players, teammates at InStride. And so I'll say that we're trying to do a good job of listing out all of the different insurances we take on our website so that it's very clear. And again, it's been cool because like we started with Optum, United, and some of the Blue Crosses depending on the states, and we're slowly but surely expanding. plan is also to get in with Medicaid. We've started those conversations as well, and we're working on the regulatory piece. So that's also happening. So if anyone ever wants to talk insurance or give us advice as to how to, we will take it. We are humble.
Yes, I'll talk it. You'll be giving me advice.
Conversation, like
Yeah.
over coffee.
No, honestly though, I will say, we do get a lot of requests for webinars on the insurance piece, both for clinicians and individuals, that I would love for us to do an updated one, Chris, and we might have you on, Mona, just because we would love, because majority of our patients were self-pay. All of our patients, for the most part, are using insurance. It's just whether they're using it for an in-network exemption or a single case agreement, is dependent on the case. But, and so a lot of people don't know that even self-pay programs, there's ways to use insurance, but then how, as a program, can you try to get in-network at a rate that you don't have to compromise the clinical care, right? Everyone knows I'm not willing to compromise that. So Here we are figuring it out, doing scholarships and everything else to make it work. Right. So yeah. What states are y'all in right now, and expansion goals, so that anyone listening can know and can go straight to your website for help?
Oh, okay. Let's see. I'm like, Alexis, where are you? So Massachusetts. So most of New England, and we're kind of expanding. So part of it is, again, we want to be able to offer service across the board to anyone who needs it, and we never want to compromise on quality. And every state is different, and we want to be integrated into the local. So we started in Massachusetts, where we obviously train and grew up professionally. So Massachusetts was our home, and then we've kind of expanded out from there. So we are now in New Hampshire, New Jersey, Rhode Island, Connecticut, New York, Maine, Pennsylvania.
I think you hit it.
Okay, excellent. And we have states. I think we have states that and geographically we're kind of going out and branching out from there. How we decide, one of our biggest decision points in branching out is also just how can we have at least 50% of the commercial lives covered? Can we be in network with the majority of the insured people in that state? Because what is also really hard is when a family reaches out and has an insurance we don't take. What we do is we will call the insurance and we'll say, hey, we'll work with you to try to on single case agreement perspective. Sure. So we're trying, but that's part of what's driving us in how fast we're expanding.
Amazing. I love it. And last question before we hop into live questions is, how do you assess for the right level of care? So how do you guys make a good determination of like, actually, we think you would do great with traditional outpatient care. You don't necessarily need our level of care, or someone's in your level of care, or even from the onset, you're like, oh, you really need a higher level of care, right? Where you're referring to OCDI Junior or to us or OCDI or whoever. Like, tell us a little bit about that.
I can jump in, and then Mona, feel free to interrupt at any point. So as part of our comprehensive clinical evaluation, we also assess for level of severity and at the outset, and then that dictates the amount of time that someone will spend at each phase of our treatment. And so it's not like a one size fits all. So if you have somebody who has more moderate symptoms, they're going to spend less time, for example, in our first more intensive phase than someone who has more severe symptoms. And of course, it's all individualized by patient, but we have sort of projected pathways by level of severity. And what's interesting is that we've had kids with more mild presentations. And I think our definition of mild is a little bit different than maybe sort of the standard definition of mild. So mild might be like 1 or 2 diagnoses, for example, and maybe a round of outpatient therapy, but not years of outpatient therapy, or not higher levels of care, for example. And so they could do a once a week model and expand it over a longer period of time, or they have the option of coming to us and doing something more intensive and compressing that time period. And so they may, for example, be in treatment for 4 months in total and see the gains that they might have realized over like a year plus or 2 years plus. So that's really an option for families. I think that the kids who have more severe presentations, these are the kids who tried the weekly model. They've been in it for years. They're just not getting that traction, or they've been in higher levels of care, or they're sort of hovering on the border of higher levels of care. And I think the challenge for some of these kids, for example, is if they're sort of like bumping in and out of the ER or inpatient, is that if they go to like your traditional inpatient unit, they may actually look where there's no exposure, it's not sort of specific to anxiety and OCD, they may look better for a period of time because they're away from all the triggers in their life that cause their symptoms. So then they discharge and their symptoms crop back up and they're sort of stuck in this vicious cycle. So we're really trying to keep them out of the higher levels of care.
Yeah. And so how, for you, if a patient, because we get this question a lot, if a patient's in your level of care, at what point would you say, they do need a higher level of care? Is it, you're not seeing a reduction 4 to 6 weeks in, what's kind of y'all's?
Yeah. So I would say for kids who have more active safety issues, that's one thing. So for example, plenty of our kids have passive suicidal ideation that kind of comes with the territory, with kids who, again, are just feeling hopeless and despondent and like nothing is working. And if it gets to the point where now it's more active suicidal ideation, where they have intent, they have plans, they have means, then we would consider a higher level of care. Mona, what else am I missing here?
Yeah, I would say that it's how the OCD is showing up and how they're feeling and their environment are feeling able to then push to kind of work through it. And so we will work. We have all kinds of different tricks up our sleeves in terms of engagement and motivation. Again, like especially being a child or a teenager, a lot of their lives are not their choice. They have to go to school. They don't get to choose their job. So the motivation to actually do the things that they need to do might not be quite as strong as for an adult, where there are other incentives motivating you to get back into life. And so we'll try all kinds of different motivational techniques, but if we're finding that a kid is just really stuck and might need a structure around them to help them get into a routine and help them just even get going on trying these exposures, we might say a higher level of care might be indicated. Hopefully a briefer stint on the higher level of care, knowing that once they get that momentum, they can come back and start doing that work kind of on an outpatient basis so that they're integrated into their lives and practicing this in their real lives. So I think that's kind of the other time where we really do. And to your point, Liz, we practice measurement-based care, right? We have clear goals and we're tracking data and we're saying, are you trending in the right direction? It's going to be up and down. It's not going to be this beautiful like curve of everything goes down or line that everything goes down. But generally we want to know that like this child is engaging in these exposures, is coming in and talking and able to identify how OCD is showing up and trying different approaches. And if that's happening, then that's hopeful that you're going to move in the right direction. If not, then you do want to catch that early and make sure that you're intervening and shifting your approach.
One thing I would add, Mona, is that we also have the option for a parent-only approach. So most of the time when a child has low motivation or low willingness to engage, our coaches are like our secret sauce to activate and engage a kid. And every once in a while, a kid is just like, I'm not going to do it. This is just not happening. No matter all the tricks that we try, it's just not happening. So then we can work primarily with the parents. And they're working on shifting the environment, which then creates that like exposure is life environment for the kid.
Love it, love it. Exposure is life. My favorite thing when people say, Liz, what will ERP look like long term? What does ERP look like next in treatment? And am I like, ERP doesn't look like anything. It looks like you living your life. Like we're not calling it ERP anymore. We're calling it like your life. Like you're going to go live your life. And that is ERP, right? We don't need a treatment plan anymore once you discharge. And I love that. I love that you guys you're treating, after treatment, the goal is like, you don't need treatment. You need life. Yeah. Your treatment after treatment should be living your life. It should not be continued treatment. And I just want to send that message. I keep hearing, Chris, you know how I feel, but I keep hearing so many people talking about like struggling forever. And, the road is always going to be bumpy and we have to expect that. And like, that is not the truth, you guys. With effective treatment, you can get freedom. It doesn't mean it's perfectly linear as soon as you step down from treatment, but long-term treatment is that you live your life, not that you are expected to have to be in treatment forever, to be in and out of the system, and to continue to need to always have these like interventions, for your struggles.
Well, one of the things we often talk about, and this is the kind of thing that I think sometimes kids feel like rolling their eyes at, but it's really true, is that The bumps in the road, those are learning opportunities. So anytime you encounter that bump, because life in general, it's bumpy for anyone, whether or not you have anxiety or OCD, but each time you hit that bump, it's an opportunity to, yes, I can take a pause and make a deliberate choice in how I'm going to respond, both if I'm the patient myself or the client, and if I'm the parent, right? So they have an opportunity to practice their skills. And so I'm like, bring on any bumps in life, because then your brain can keep learning, can keep creating those new neural pathways.
100%. Chris is gonna, like, he's looking at me because he's like, we have 13 minutes left. We have so many questions. Sorry. Okay. So we're gonna do rapid fire, because I love rapid fire, where we just we ask it and we're direct. So Chris, I'm throwing the first one to you. What are the panel's thoughts of including ICBT and RODBT into OCD treatment instead of capitalizing on the traditional ERP route, especially if they're not ready or not progressing with ERP?
Yeah, one thing I wanted to say to answer this question, and I think it was really well talked about at this panel. I hear a lot of times clinicians that do a traditional 50-minute session model saying ERP doesn't work. And at my treatment center, we do have a higher level of care. We have an IOP, one-on-one IOP. We've sent a lot of clients to Liz's treatment center, and those clients that were not able to do ERP thrive in those environments. So what I would say before abandoning ERP is, I want to shout this from the rooftops, is the right level of care is so important. We get so many clients that come to our IOP that have failed ERP, and I'll sit with them. They have a 32 Y-box score and they can barely leave their house. And I'm like, no clinician, no matter how many books you've written, can do that much change in one or even two 50-minute sessions. It has to be a higher level of care. So whenever I get questions when somebody's like, hey, ERP didn't work for me, the first question I always ask is, what was the top level of care? And it's always weekly sessions. And I'm like, that's why it didn't work. As a clinician, I've been trained in ICBT. I've done training. We had a clinician that worked at the DBT Center of Orange County that trained me in DBT, RODBT, got trained in motivational interviewing. I've done trainings in acceptance and commitment therapy. What I always fall back on is, for me and for my clients and from the research, ERP always has to be a part of treatment. There has to be a behavioral change. We can understand what's going on in our brain and any of these other mechanisms I've talked about. You can understand your value base. You can learn to be motivated and buy into treatment. But at the end of the day, we've done so many behavioral things to feed the OCD. We have to start doing behavioral things that get us back into life. So I'd always be cautious if somebody is trying to get you to do, ERP is gone in the treatment modality. I've heard some people like some of these other, modalities that we just mentioned, but I'm always challenged to find a person with OCD who's like, I only did this and never did ERP, and I got better 100%.
Are we allowed to just say +1, +1, +1?
Yes. No, I mean, again, it's the thing is, I think that I always tell people, one of my favorite webinars was one, Chris, we did with me and John Hirschfeld. And I said that, guys, for 10 years of my life, I would have been someone saying ERP doesn't work for me. But it wasn't that ERP didn't work for me. It was that I wasn't ready for ERP, and I was doing it with one foot in, one foot out. And yes, I wasn't actually doing ERP. And so, and I'm not saying that's the case for everyone, because again, if there's comorbidities, ERP doesn't work for eating disorders, right? There's some evidence now, but you know what I mean? Certain substance use, we're going to use a specific substance use intervention. And so there's always caveats, but I want us to really be before we say ERP doesn't work, I want us to be able to answer the question of, why is ERP not working? Is this values-based ERP? Is this, ERP that makes sense? But also, are we really doing ERP? Are we doing it all the way? Or are we kind of doing it and hoping it'll work, but we're still ritualizing or still holding on?
Yeah.
Hey, that's exactly what I would want to know. So I would want the person to describe to me what the exposure looked like. So for example, I often hear about ERP without the RP. And I'm then you're not doing it. Yeah. Or to your point, Elizabeth, I think it's the how of exposure. So are you doing it sort of white knuckling the whole time, or are you really leaning in and letting go? And I think that piece matters so much.
And again, is it values-based ERP? Is this ERP that you want to do because you see the value in it and you see how it lines up with those strengths that you have, those things you're wanting in your life? Or is it ERP that you're being told to do, but you don't really see why you should do it?
Mm-hmm. Yep.
All right, Mona, we've got so many questions for you, so we're going to hop to the next one.
Yeah, I'm going to rapid fire, Mona. So there's three medication
Go ahead,
questions.
Chris.
So at
Go together.
1219 from Simple, what's the more advanced treatment for OCD other than an SSRI? So if somebody's on an SSRI and let's say it's not working, is there other medication interventions that someone can try?
Well, I would say the first thing I will say is the same thing as you said for ERP. Is I ask, what was your SSRI trial? And because what we've seen is that the one of the main reasons SSRIs don't work is non-compliance with the actual prescribed the actual prescription. So not taking it as prescribed, taking it intermittently, missing some doses, or kind of intermittently taking it. So one is just have you taken the SSRI as prescribed, and then looking at the dose progression and the timing. What we know is that they are slower to work, and so we're looking for them to have effect up to 24 weeks after starting. I mean, again, peak is around 4 to 6 weeks, but they can take time. And then what does it mean for the SSRI to work? We're not necessarily looking for them to take away all emotions, to take away the OCD, to take away the anxiety. We're looking for a decrease in volume so that you can then engage in the exposure work. And so some of it is, what is your goal and how are you defining what works means? So I'll start with all of that, because SSRIs can be very effective, and we'll often start with one. If that doesn't work, we'll go to another SSRI before moving to different ones. The SNRI category, again, they're similar. So, but I would say that now, so I'm a pediatric psychiatrist, so I'm so used to off-label and simultaneously have to give the disclaimer that this is, I'm like, just be mindful when we're prescribing a lot of this, it is off-label. So we go by expert, like we talk with each other. We want to be really careful and think through how we're prescribing, but we'll sometimes use a tricyclic like cloprimamine, like as an adjunct. So if we have an SSRI that's been partially helping, we might do a low dose as an augmentation, or we might go to the atypicals with augmentation. There are some newer medications that have come about. Again, I'm in the child world, so I'll say we're a little bit more reluctant to use some of these medications in the developing child brain without kind of being able to see longitudinally how it impacts. We get asked about ketamine a lot, so I have lots of thoughts about that, but I think we're supposed to do rapid fire, so that can be another time.
Let's do it. Let's talk ketamine. Let's talk psychedelics. Come on.
At 1221, Joey C asks, what is the role of benzodiazepines in OCD treatment? Can it make OCD worse?
That's a great question. And so again, there's not great evidence for use of benzodiazepines with OCD. Or with anxiety in general. But what I will say is that clinically, so again, this is off-label, this is clinically how I'm giving you my thoughts. Where I've found it most helpful is in that initial bridge phase of saying, when somebody is just having a hard time accessing, getting into the therapy room to have that conversation about where they're going to start, it can be something that might help lower the intensity of the barrier to get in. And I will usually say this is a 2 to 4 week bridge, or like, let's see what impact it has and decide whether or not we keep it. The nice part about a benzo, it's quick on, quick off, especially depending which one you choose to use. So you kind of quickly know what impact it's going to have. I do not like using it when we've got somebody heavily involved in exposures. It hits the GABA system. That impacts memory. There's some concern that when we're talking about new learning, like you have your kind of OCD, your old learning, your fear memories, your cycle, we're trying to create new learning in the brain. And does a benzo impair that consolidation of new memory? So does it potentially make the treatment stick less strongly? I think there is some concern there. And so again, or is it a safety behavior? Is it one where, I've got my benzo, I take it and I can do these things and I feel better, but you're not developing the new relationship to OCD that we want you to. And so again,
remember, right, what we're trying to teach you behaviorally is that you can do hard things.
Exactly.
And a benzo teaches you the opposite, no matter what, right? Because it's really teaching you that like you can't tolerate anxiety. Right. You don't have the ability to feel that distress, and you need something to feel better. And so I find clinically, like so many of our folks, right, that come that are, is not just do they have to get off benzos, but also then we have to like really help them shift their whole mentality around medication reliance to feel better versus actually, can we ride the wave of anxiety?
Completely agree. So if we had to sum it up in like a few rules, I'll say that if we're going to use it, it's incredibly short term and fully in effort to help actually access therapy and engage in therapy, and then take it off, and not as a PRN. So not as a rescue, but instead as to take down the intensity so that you can start engaging. And once you're engaging, take it off. If you even use it. Again, we're pretty limited in how much we do.
Kat, I have a question at 12:31 from Amy. Tips for encouraging a young adult child to finally get ERP treatment.
Well, that's a great question. I think it goes back to what we were talking about earlier, is that values piece and figuring out how to make treatment really meaningful for that person. So it's less about you're doing this because your parent or your friend told you to do it, or you feel like you should, or you need a certain reduction on the Y box, but because you want to get back the life that you were living before. You want to get back the things that matter to you. You want to get back to being the person that you were, and you want to get back to the driver's seat of your life. And so really taking the time up front to lean in around the values piece and to really connect with this person to build their motivation. We do an activity at the outset around, we call it the My Life activity, where we have somebody draw a pie chart. And in that pie chart, they're depicting the different areas of their life and how much space they're each taking up. So they will include anxiety or OCD in that. And oftentimes what we're seeing is that anxiety or OCD at present is like 5/6 of the pie chart, and that wedges out everything else. So like school and friends and family and work and extracurriculars and all the things that really used to matter are like this small wedge of the entire pie. And then we say, and what do you want your life to look like? And now all of a sudden, all those other things are coming back online. And so then treatment becomes about, well, then how do we get those things back online? How do we open up the slices, the important slices of the pie for you?
Well said. I'm going to rapid fire to Liz. Last question from HG at 12:30. Since OCD could run in families, but is also conditioned behavior, do you recommend any early intervention programs for children who have a parent with OCD?
Wow, great question.
I know we've never gotten that. I was like, we got to ask it.
Yeah, I haven't gotten that question. I think my first advice would be that I want to make sure the parent is really well treated, because again, I see anxiety in my kid, right? My daughter's 3. I've seen some early OCD signs of like things needing to be up and her being triggered if they're not in the right place and what's going to happen. But because I'm so well treated, like I can intervene really quickly, right? And help do some active fun exposures that will hopefully OCD won't progress. And so I think that if the parent is really well treated and really knows the tools, you're going to be teaching your kid, right? Because you're living that model of we can do hard things and fear doesn't have to win. And that's kind of how you raise your child in your household. But I certainly think if there's any signs and symptoms, the earlier we can intervene, the better, right? We know that as with any condition.
Well said.
Yeah, very well said.
Okay, well, we will let y'all wrap up with final words, but I just want to say thank you for everything. Thank y'all for coming on, but also thank you for what you're doing. I think it is really remarkable to have a new resource that is going to be so accessible to so many people who need it, offering evidence-based care. So this is something we get asked for all the time, and I'm just super excited and honored to be able to have y'all on, to be able to talk about a resource that's finally available and has been needed for a long time.
Well, thank you all. And thank you for the incredible work that you're all doing in this education. So valuable and so powerful. And looking forward to seeing you at ISCDF.
Yes.
Thanks so much.
All right, Chris, take it away.
Yeah, no, just super, super happy to have you. Thank you so much. I mean, what people want is more resources, more access to care. And we were excited to bring you on and give people a new resource. And I just hope everybody watching, I think the thing I want everybody to take away is like, if you are working with someone for 3 years, once a week, and just not seeing the results that you want, please look into a higher level of care. We've all on this panel have seen lives changed from that. So please, please, please look into that. And we hope to see you in July at the Orlando conference, the last week in July. Registration's open. Sign up and come hang with us.
Make sure you sign up. My last plug that I love that y'all mentioned earlier for, InStride and any programs is that so many times I get asked the question like, well, how do I know I should pause and focus on treatment? And what I always tell people is that sometimes an opportunity to do intensive treatment in a short format is going to feel so much shorter, even though it feels longer up front, than in the long run, right? Having therapy go for 2, 5, however many years. So if there's opportunities to condense and get that treatment and get back on your feet quicker, I think the learning happens better, right? We get to practice it more often and frequently, but also it just sets you up for so much more in the long run, right? So always think about kind of imagining that like intensive intervention, that we get those amazing results faster versus this longer process. So always make the time for treatment, you guys. It will change your life and get to a place where you don't have to spend your life doing ERP. You get to spend your life living life. And that's what we want to teach you.
Well,
Thanks, you guys.
Thanks for being with us today.
Thank you so much.